to be here and to give the lecture on uveitis. So the aim of the lecture is, there are several aims for the lecture. First, the lingo of uveitis. So what are we talking about when we discuss uveitis? Second, I would like to touch quickly on anterior uveitis. And then third, I would like to just highlight a few points that make you suspect that this is infectious uveitis or masquerades. And then finally, I would like to finalize by touching on what not to do in uveitis. So I'll try to tailor the presentation so that it suits comprehensive ophthalmologists and retina specialists as well as uveitis specialists. And in my personal view, I think it's not about taking new knowledge, but it's mainly trying to understand how to think about a uveitis case and how to play it safe, rather than just gain knowledge, because I think most of the knowledge I'll touch on you actually know. So very important, any uveitis is actually infectious, inflammatory, or masquerade. Any uveitis. So if you go for anterior uveitis, for example, it's the same vitritis and retinitis as we're going to see later on. So when anyone asks you about the cause of uveitis, so always think about infectious, inflammatory, and masquerade. And thinking this way is good, because then you can really, you have the mindset to try to reach the diagnosis. And then some cases are actually undifferentiated. Actually, a lot of cases are undifferentiated. So if you look at anterior uveitis, the majority of the cases are HLA-27 positive or undifferentiated. I just want to tell you a few bits on anterior uveitis. We all manage anterior uveitis. One thing to remember is that when you have a patient with anterior uveitis, as any other case of uveitis, history is very important. So you want to know if this is the first episode or it's a recurrent episode. And also you want to know about the systemic history, if they have issues, medical treatment, back issues, etc. Few points. So if you have a patient with anterior uveitis, if you are to treat them for 6 weeks and always hit very hard. So I give them prednisone drops hourly, and I taper down to stop over 6 weeks. It's very important to give them a 6 weeks course. That decreases the chance of them becoming chronic. The other very important point, if you have a patient who's flaring up between episodes less than 3 months, so for example, you give them prednisone hourly for a week, 6 times for a week, 4, 3, 2, 1, stop. And then you saw them in the middle, and then a few weeks afterwards, they're fine. But then they flared up in 1 month or 2 months. And that keeps happening. This patient actually has chronic anterior uveitis. And the reason they are flaring up is because you're stopping the drops. And that's completely a different ballgame from patients who would have recurrent anterior uveitis, for example, every year or every 2 years, or every 3 years, because these patients will get this acute treatment again. But the other patient, they need steroids on a long term. So we may go like, for example, like when we taper down once a day for 2 months, or and then every other day for a few months. That's actually a very crucial point. Another point I want to touch on, we published on this, the prostaglandin analogs, particularly in the non-acute uveitis, are not contraindicated. And they actually, it's not really true that they increase uveitis and CME, especially if we're talking about patients in the non-acute stage. And the last thing really to look for 2 things in anterior uveitis. One of them is Fuchs heterochromic uveitis with all its characteristic features, because we tend to overtreatment. We tend to overtreat these. And the other one to look for is always to look for iris defects and cornea changes in patients with acute uveitis or recalcitrant anterior uveitis, because that makes the diagnosis herpetic uveitis, and these patients will benefit really well from antiviral treatment. So this is a nice algorithm, or I hope it's a nice algorithm that we put together. So if you have a patient with anterior uveitis, we give them a 6 weeks course. We give them cycloplegic if there's severe pain and severe reaction for a few weeks, and then we stop it. Then usually we go for 6 to 8 weeks. If inflammation flares up after more than 3 months, that's a recurrent anterior uveitis, recurrent acute anterior uveitis, and they need repeat treatment. If they flare up less, then it's actually a chronic uveitis, and that's where you need maintenance treatment. If there's no response, always reconsider the diagnosis, whether it's a diffuse heterochromic uveitis or missing a herpetic anterior uveitis, because they should respond well. Then we may go down the route of adding systemic steroid, but usually with anterior uveitis, we don't need that. So I think what I would like to touch on is this point here, the Fuchs heterochromic uveitis and the herpetic anterior uveitis, and also about the 3 months period between episodes. All right. So I'm happy to entertain any questions if you have 1 or 2 questions on this before we move on to more cases on the posterior uveitis. Dr. Tari, if you have any questions or if you would like to. Please type it, please do type it, and we can, and Dr. Tara is kindly moderating, and we can go through them. Okay, I'll keep going. I mean, as I said, I think the important thing really is the, yeah, I'll try to just read them, you can see them. So yeah, they should improve in 1 or 2 weeks, really. So we tend to see them if the pressure is not very high, if this is not a child, if there's no fibrinous uveitis or hypopian uveitis, then we tend to see them in 2 weeks. And then after that, we see them as they are tapering off the steroids to make sure that they're not becoming chronic. But if they're fibrinous, very high pressure child, then we would like to see in 1 week. They are both very similar. Durazole is more potent, but both of them are similar. Dexamethasone or prednisone, so both of them are fine. In a way, but I think as we will know that, we will come to know that in anterior uveitis at the end, you can actually be tolerant to maybe trace cells, and maybe if the eye is very quiet, to +1 cells. But initially, especially with the acute ones, you want to try to eradicate it. For something like a GIA, you would not accept any more than trace cells. So yes, you could be tolerant to some trace cells if everything's quiet. It's mainly herpetic uveitis. I mean, there are other causes really for transillumination defect, but in the context of acute anterior uveitis, that's the most important. So always really think of the cornea and the iris to make sure this is not herpetic. And if I'm suspecting, then what I do is I do an AC tap and send it for viral PCR. And if it comes back positive, then you have really proof to put patients on long-term oral valacyclovir, and they do so well. They do very well. So something to think about. So always think about chronic, Fuchs, and also the viral when you're dealing with anterior uveitis. Okay, I'll move on with a case here again, just to try to get more about like how we manage uveitis case. 40-year-old patient coming, decreased vision, one eye, 20/80, everything is normal except the fundus in this eye, and it's a 5 days duration, and that's the appearance here. So very dense vitritis, you can just barely see the disc here and the major vessels. And really you look in the other eye and there is nothing. So we're dealing with, we don't know what's happening, right? So again, coming back to the same thing again, could this be infection? Could this be inflammation? Could be masquerade? Especially if people do retina work, you know that sometimes actually vitreous hemorrhage can look like vitritis, PVD can look like vitritis. But again, if you're aware of these things, you can easily tease them out, but just something that we see in clinical practice. So the question is here, okay, well, it can be any of these. So what are we going to do? So the rule is always exclude infection as much as you can before treating as inflammation, and keep masquerade at the back of your mind. So that's the rule. Exclude infection, If you really cannot find anything, treat as inflammation, but be cautious and keep the door open for it, maybe a masquerade. So the main worry here is that this patient would have a viral retinitis. That's the real main worry. So it could be, I mean, there's no history to suggest bacteremia, a patient is well, there's no history to suggest TB, but it could be really any of these, and it could be, as I said, inflammatory or sarcoid or masquerade. So what we do in this case is we need to cover for viral retinitis. That's the most important, because if we don't treat this patient in a few days, the patient will, yeah. So in few days, if we don't treat this patient, the patient will end up with retinal detachment and severe retinitis affecting the whole retina. So what we would do is like this. We'll get blood tests for tuberculosis, syphilis, toxoplasmosis, and serum ACE. We'll get a chest X-ray. We're lucky enough that where I work, we get the syphilis serology on the same day after a few hours. And then we will treat it, and then we'll do a vitreous tap, send for viral PCR, and we'll treat the patient with high-dose oral valacyclovir. And then see what happens next, whether the patient is going to get better, what are we going to get from the blood. But I think the message here really is always exclude infection, and from infection, the most serious to cover is viral retinitis. If I'd be grateful if you can just mute so we don't get interruption with the lecture. Let's talk a little bit more about, again, yes, I will. Sorry, I took the screen off. Okay. All right, fantastic. Okay, so that's really the most important, is to cover for viral retinitis. There are cases here. Let's talk a little bit more about retinitis. So again, we have a retinitis. So is it infection? Is it inflammation? Is it neoplastic? Retinitis actually is an easy one. If it's not Behçet, it's an infection. And that infection can be bacterial, for example, a syphilis, could be viral, could be toxoplasma, could be fungal, but usually it's more choroidal than retinitis. Otherwise, it's actually, or syphilis, or masquerade, one of the masquerade. So this one is easy. You have a unifocal retinitis next to a scar, and you have this arthritis going on. So that's really a spot diagnosis. All what you need is blood tests to confirm the diagnosis and make sure that this patient also does not have syphilis. And then we treat as toxoplasma. This is a reactivated toxoplasma retinitis. Again, just remember the differential diagnosis here. Okay, and the differential diagnosis of retinitis is not very different from the differential diagnosis of vitritis. From anterior uveitis, again, it's infection, whether it's bacterial, viral, protozoal, or fungal, and inflammatory, and then masquerade. Okay, this might be a little bit of a more difficult one. It's a unifocal retinitis with an branch artery occlusion next to it. That's actually a primary toxoplasma. So unifocal retinitis in the posterior pole is most likely toxoplasmosis, even if there's no scar. That's actually a primary toxoplasma. Again, that's an easy diagnosis because of the phenotypical presentation. This one should be easy. That's again a healthy Brazilian patient, one eye, got peripheral retinitis and hemorrhage. Again, could be anything, but most important here was multifocal peripheral retinitis is acute retinal necrosis. So we get blood for syphilis, we'll get TB as well, we'll get toxo, which is unlikely to be like this, but here we have to cover for viral. So we'll get a vitreous PCR. We usually put intravitreal foscarnet and put the patient on high dose oral valacyclovir. And the viral PCR is fantastic because if it comes negative, it's very, very unlikely it will be a viral problem. And this patient actually had herpes simplex type 2. retinitis, and it did very well. This is a tricky one. So it's an area of retinitis. It's mainly one area, but there's an area next to it, but it's not very central, not very peripheral. So the main etiology here, if we exclude syphilis, if you look at the list again, it's actually viral or toxoplasma. And that patient had as well viral retinitis and did very well and healed very well. History is very important. So same picture here. If I tell you this is an Asian patient, very significant chest symptoms, bilateral retinitis, and this is the presentation. You can see areas of retinitis and vasculitis. And that's a Vietnamese patient when I was working in England, and there is a very high TB in this population. And that patient had actually a TB retinitis. But if I give you the same presentation, the same, clinical appearance, but I tell you there's a Mediterranean, mouth ulcers, oral ulcers, genital ulcers, then you'll be thinking of Behçet. And that's why history is so important. Just be wary, again, because I'm aware of a case that, again, presented very similar, bilateral, peripheral retinitis with vasculitis, Turkish patient in Germany, oral ulcers, genital ulcers, and actually, unfortunately, was a bilateral retinitis, which is very rare. And patient, of course, did very bad when was treated as Behçet. So there's always a period where you may doubt yourself and may even don't start treatment and do an AC tap, which is fine, and send for viral if you're really still suspecting it's a bilateral retinitis. Very, very unlikely. But again, the point here, history is very important. Okay, I'll give you just one interesting here and we'll finish on retinitis and we can entertain some questions. This is a very interesting case. It's a primary care physician who had this recurrent areas of retinitis healing, multifocal retinitis. And the thought was this is a viral retinitis, but had 2 times vitreous PCR and was negative. So that really was very interesting. And bloods were negative for everything. So what I did not tell you is that sometimes toxoplasmosis, if you're old or immunosuppressed, can present as viral retinitis. And that patient actually, when we did a vitreous tap, again for toxoplasma, it came back positive. And this patient had toxoplasma retinitis. But in elderly and in immunosuppressed patient, it can behave very much like a viral retinitis. And this was a very interesting case. This is other eye and it kept progressing and we kept really repeating the vitreous tap and doubting ourselves until we thought, okay, well, let's actually look for toxoplasma as well. And at that time, we were not able to do toxoplasma and viral at the same time. We had to do one at a time. Now we can, even if with a very small sample, we can send for both at the same time. Okay, so so this patient took plasma and did very well. And this is actually another interesting patient who was just old and had this very severe necrotizing retinitis. And this eye was gone, and we just wanted to make a diagnosis to know for the other eye, which was normal. So we did a chorioretinal biopsy, and you can see here actually there's a toxoplasma cyst. And this patient actually had a toxoplasma retinitis, a very severe toxoplasma retinitis. And the main problem was just he was old. So in elderly, you can get that. Again, on here, this is a patient with retinitis that not responding to treatment with valacyclovir, had vitreous PCR, and had also looked for toxo PCR and was negative, and the patient is getting worse and was referred to me from a retina physician. And here, if you go through the list, actually one of the differential is Behçet, but then she doesn't have any stigma of Behçet, sarcoid. But again, one of the important, especially in old patient, is toxoplasma. And this patient actually kept progressing. That's when she came to me, and she had T-cell lymphoma. And unfortunately, she died afterwards. We treated her with methotrexate intravitreal. She did so well. She survived for 2 years, and then she died from brain lesions. And that's another typical appearance of lymphoma, where you get the infiltration of the RPE. So you can get a picture of retinitis, like this one, or you can get the RPE infiltration like this, or you can get just severe vitreous opacities, and that's why it's in the differential diagnosis of vitreous opacities. Okay, so here's the list again, and retinitis is really an easy one. If it's not Behçet, most likely it's infection, and the most important to cover is viral, and always keep the door open, particularly in old patients for lymphoma. Very happy to entertain any questions on this part of. Okay, if we don't have questions, I'll just give you this one. This is actually a very interesting case, and again, it touches on the same way of thinking about things. This is a patient who came I think on a Thursday, came with very severe anterior uveitis with hypopyon, with posterior synecdoche going on for a few weeks. And then the fundus, that's all what we could see in the fundus. Just some red glow and the retina is attached, significant vitritis and problem mainly in the center. And then the B scan, you can see there are some central lesions and vitreous opacity. So the question is what to do. And again, I did the same thing that I showed you before. So infection, inflammation, neoplastic, infection. We're not reaching to anything with this patient. He's denying everything. So we sent bloods mainly for syphilis. And we also did an AC tap for vitreous, for viral and toxoplasma PCR, and put him on hourly steroid, gave him oral valcyclovir, and we saw him the next day. And I was hoping that the hourly steroids would be. There's also, I'll give you another case here. This is an interesting case with a patient coming with decreased vision in the right eye. This patient is still 20/20, but he has a problem with this eye. In the other eye, he has decreased vision 20/60, and many years back he had inflammation and nasty appearance, which looked like a vasculitis with pigmentation. Then this patient had syphilis, and it's very interesting. This is his autofluorescence here. This is his OCT, and this pattern is suggestive of interrupted outer retina in a young patient, very suggestive of syphilis. And this patient did so well with syphilis treatment. You can also have disc edema with uveitis. So always remember the combination: male, high-risk behavior, macular lesion, disc lesion, arthritis, skin lesions. That really you need to think of syphilis. Okay, I'll give you one more case, and then we can stop and entertain questions again. This is a 36-year-old female, headache, decreased vision, 20/20 vision. And this is the right eye, and this is the left eye. Let's just get close pictures of the lesion of the right eye and the left eye. That's more close pictures. So you can see more of these like outer retinal choroidal lesions, right? And again, there's a differential diagnosis here, but this actually more again of a pattern recognition. And this patient, as you would see here from her OCT, and later on the lesions would appear more on the fluorescein, where the lesions are more hypofluorescent and become hyperfluorescent. Similar in the other eye, and you can see them here with the ICG. We can see the areas of hypofluorescence, this patchy area of hypofluorescent or hyposcyanescent due to the choricapillaritis. And this patient had ME. And so here, again, the most important reason is to exclude infection, particularly TB and syphilis with AMP. So that's what we did. We had a screen. She had TB, she had syphilis, serology was negative. We thought, okay, well, this pattern is very suggestive of AMP. Usually I treat AMP if the vision is decreased. That's a success. And if the vision is decreased, and this patient did well, but you may not treat them. But where I trained, we tended to treat them if the vision is decreased, because you don't want to miss the chance that this could be not AMP, it's another inflammatory lesion, and you did not treat this patient. So I tend to treat AMP and mutes with steroid, but that's not the standard. Okay, so this is another differential here, is when you have like these multifocal big lesions, and you may suspect actually TB. TB can give a pattern like this, and that's why we test these patients routinely for TB and syphilis. So this is, again, same thing, really, differential diagnosis. When you have a choroidal lesions, you want to be thinking more. Again, same line, bacterial, protozoal, fungal, viral. Viral, you get more retinitis. We don't see choroidal lesions with viral. Inflammatory, these are the most important. So all the white dots, they can give you a pattern like suggestive of choroiditis, VKH, and sympathetic ophthalmia, and bird shot and sarcoidosis. And always keep the door open for masquerade. So the rule is exclude infection, treat as inflammation, keep the door open for masquerade. And that's what we did in this case. Suggestive of AMP, we got TB and syphilis out of the way, and then we treated with steroids and see what happens. And I wouldn't treat with intravitreal steroids ever in new case, because you cannot reverse this. If things are getting worse, you can stop the systemic steroids. So systemic steroids, at least initially, is your friend, and not the intravitreal steroids. Once you have an established diagnosis, you can actually treat the way you want. Okay, so if you be kind to all mute, so the question is how to think that this is an infection etiology. So there are things that can make you suspect infection etiology. First, comorbidities, sick patients, recent admission. Patients who are really sick, very bad diabetes, that would make you suspect that this is an infection etiology. The other thing is, if we can please all mute, I would be grateful. Thank you. So again, the other thing is in the social history. So for example, someone in contact with animals, that's really something you would may suspect, like for example, brucellosis or leptospirosis. Pets, a cat or a dog in the house, that would be something may get you to suspect the infection. Sexual history is very important, particularly men having sex with men and multiple sexual partners. That's very important. And under the sexual history is intravenous drug use. Retinitis, this is actually an easy one. So the rule is that retinitis is an infection unless it's Behçet, and the other one is lymphoma. But if you have a retinitis, it's really an easy one, and it's usually an infection. Remember, we talked about AMP and serpiginous, and you need to exclude TB. If you're worsening or not improving on steroids, I would really think about infection or masquerade, because usually most patients with inflammation would improve on steroids. The question really is what happens as you wean off the steroids, or if you're getting side effects from steroids. But introducing second-line immunosuppressives in most cases does not really improve the management much from the inflammation point of view. You could argue that biologics do, but the standard is that most inflammation, if not all, would improve on steroids. So if they're not improving, there's something really wrong here. And it's difficult, and we all really make mistakes. And that's why you really need to always reflect on your practice and learn from mistakes. The other thing really is these cases are difficult. I would refer them to a uveitis specialist, because then they will have experience. There's always a pattern recognition that happens. And yeah, indeed, these cases are difficult. Dr. Tariq, any questions? And or anyone, any questions? If you can, I can see here the questions on the chat. Okay, I got some. I can see that actually the chat questions now. Okay. So this is a great question. So really, and if you look on PubMed, so I wrote something on a website. It's on PubMed. I can't remember actually the name of the platform. But if you look at ocular tuberculosis and my name, you'll find that actually we did like a nice review article, a very short, easy review article. So there are patterns. One pattern is that patients come with a choroidal, like a tubercle or a choroidal granuloma, which could be multiple or large. So if you have a granuloma-like lesion, you want to be thinking of actually tuberculosis, right? The secondary is you can get TB vasculitis. Remember what we used to call Eales disease? Eales disease, most likely TB delayed hypersensitivity vasculitis. Just exposure to TB antigen elicits a vasculitis. So when you have this pattern of Eales disease, you need to think of TB. The third thing is what I showed you, ampy and serpiginous. When you have a pattern of ampy and serpiginous, we always test them for tuberculosis. So these are the ones we tend to test for tuberculosis. We treat with anti-TB in collaboration with the Department of Health or the pulmonology department, as well as we give them systemic steroids as well to taper down. And so we give them like a 3-month course of systemic steroids. And some of them even may need second-line immunosuppressives, which is fine as long as you treated them with anti-TB. PCR is actually not very helpful at all. It's on the experimental level, but it's not very helpful, and that was shown in several studies. That's a good point. You can start. I mean, you can start and you can stop it, but I would start systemic steroid cautiously. And I think as long as we're not dealing with viral retinitis, I think starting even systemic steroids is fine. If it's an infection, you can switch it off. I mean, we're fortunate here. We get syphilis serology in no time, in few hours. We get viral PCRs in a day or two. But I would not start systemic steroids if I'm suspecting viral or I'm not sure. But for example, choroidal lesions, and you think there's nothing to suggest TB or syphilis, yes, I think that's fine. I would start steroids. But retinitis or very severe vitritis and you're not sure what's happening and this could be a viral PCR, I would not give steroids in this case. IM and IV, yeah. Yeah, so I don't guide it. So infection disease here treated. When I used to work in England, at the end they used intramuscular mainly, and they did not do lumbar puncture because they said, well, actually, and they did not do MRI brain because they said, actually, we're treating them anyway for CNS syphilis, so it doesn't matter. Here, they are shying away from lumbar puncture now for the same reason, but they treat with IV. But they have treated patients with IM as well. But I don't guide it. I leave it with infection disease. But all of these patients, 48 hours after treatment, I give them 2 weeks of steroids, 40 milligram for 2 weeks and just stop because they sometimes go on to get Jarisch-Hexheimer reaction where it gets worse. So I give them 40 milligrams steroids starting 2 days after treatment for 2 weeks and stop. And just a useful tip here I learned before during my fellowship, you can give the patient a whacking dose of steroids, and as long as you're not over 2 weeks, you can just stop. Because to have pituitary adrenal suppression, you need 2 weeks or more. So that's sometimes useful, like after surgery or in this context we're talking about. So I think it's a definite TB exposure, right? It's a definite TB exposure. It's not definite TB. So it's definite TB exposure. So you need to really understand that in this context, that you have lesions that actually phenotypically can go with TB, and then you have that blood test or the PPD. Then you say, okay, well, actually, the findings of the lab results support the diagnosis. So this is a presumed TB, or highly suspected or presumed tuberculosis uveitis, and that would need treatment with TB, uveitis, and steroids. Yes, true. That's another thing as well. It could be, and that's really one of the reasons not to start steroids early. But we very rarely here do tuberculin. We do quantiferin or T-spot. A vitreous tab. I do a vitreous tab using a trocar I actually have a video for this on the AA website, and I'll show the link now, or I'll send you the link. It's actually an easy one. Fungal, usually it's a choroidal lesion. It comes, if you imagine blood lesions and candidemia and the choroids, it comes from the choroid. So initially it's an elevate rate. Initially it's a choroidal lesion that's flat and then becomes elevated, and then it buds in to go into the retina and then into the vitreous. So viral is not like this. Viral, the main presentation is viral retinitis or vasculitis. So actually, they are completely different entities. Having a viral PCR as well supports the diagnosis. It's positive more than 90%, while a fungal a vitreous sample positive for fungal is only achieved in about 50 to 70%. So it can be negative and still it's a fungal. Yeah, so we start them once TB treatment started, and usually you taper steroid over 3 months and then stop and see what happens. If they flare up on a very small, if they flare up when you stop, you try to go back on a very small dose. 5 milligram prednisone is a tolerable dose. They don't get side effects, provided you're protecting them for the bones. That's the most important. They don't need gut protection. But if they are flaring up still on 5 milligram, you don't want to keep them on high dose steroids, because that's what causes problem. So then you want to have a second line immunosuppressant. And that's the rule really with any steroid use. You taper down, you stop, you see what happens. It flares up. If they can be maintained on 5 milligram, then you don't need a second line immunosuppressant, except in certain diseases that we know that are very, very bad, like for example, Behçet or Burchard, for example. But if they are flaring up on 5 milligram, then you don't want to give them more, because they will get cushingoid and will get all the bone problems as we see them in the clinic. So then that's where you introduce a second line immunosuppressive. I think you can. I mean, unfortunately, you can. We've done that as well. But I mean, we're fortunate that we have viral PCR, and you can do AC-TAP as well, which in most series came as like very similar to vitreous in the yield, and it's a simple procedure. But I think yes, you can treat empirically and see what happens. The rule is if you have a unifocal retinitis in the posterior pole, that's toxo. Peripheral, especially multifocal, that's viral. In between, that's tricky, like the case I showed you. And you can actually do both. You can treat both. You can do toxo and oral valacyclovir as well. So you can give them Septrin and oral valacyclovir. And we've done that as well before as well. Okay, yeah. I think it depends on in the context, right? So, for example, if you're suspecting viral, we do it all the time. If we are suspecting toxo, that's usually an empirical diagnosis, and we get bloods only to exclude syphilis and get bloods to support toxo diagnosis, just antibodies, IgM and IgG. So we don't really test for that. Particularly, that's 35% of actually toxo retinitis. If you do a toxo PCR, would be negative. So vitreous PCR for viral is fantastic, because if it's negative, it's unlikely it's going to be viral. For toxo, it's not that fantastic. Fungal, we would tap them. The chance that it will be positive is between 50 to maybe 70%. For endophthalmitis, it's in the range of 50%. So actually, you need to just you need to understand all these issues. For lymphoma, it's about 50%, and that's where you may need to have a chorioretinal biopsy. Yeah, no, I like vitreous tab because we had the odd case that she was negative from the AC and positive from the vitreous. So we try not to just confuse ourselves and we do vitreous tab, but many people do just AC tab, simple and safer. So I agree. And there was only one paper that showed that actually vitreous is more superior than AC tab, right? I can actually show a video. I'll show a video. So I just use a needle, but I'll show a video for a technique I tend to use more now, especially if I'm injecting. I can show that quickly. Let me, Doctor, if it's okay with you, Doctor, I'll finish here very quickly and then show the technique. Is that okay? Okay. This is just, with uveitis, you have to have high index of suspicion in what's happening. This is actually an interesting patient, a pilot in a civilian airline that I fly with, and was referred before epiretinal membrane peel, right? So as a retinal surgeon, you would like, once you get an epiretinal membrane, you think you'd be very happy, easy cases, everyone is usually happy. And then actually, yes, he does have an epiretinal membrane, right? But there's something wrong with his retina. His retina is thin for some reason, and he did not have, and when you see this pattern here with this dip there, like with this area, with this like, sorry, trying to move the mouse. But when you see this irregularity, you think, did you have a vitrectomy before? And he says no. Then you think there's something wrong really. And then when you listen to the symptoms, it's not distortion, it's just like he's blurred. And there are floaters. So we get FA, so we can see something happening maybe with the FA, right? And then we get ICG, and with ICG you get the hypocyanescent lesions. And you tend to miss this if you don't, you tend to get them as well a bit with the OCTA, but if you don't do ICG, you tend to miss this. And actually, interestingly, this patient had, and you can see his retina thin. This patient had a Birdshot disease and HLA-29 positive, and now he's on combined on cyclosporin and CellCept and is doing fantastic. So always have high index of suspicion. I think the combination of retina and uveitis is a fantastic combination, because then you can really like suspect things outside uveitis. So when you have young patients with epiretinal membrane but the retina is thin, think actually this could be a secondary epiretinal membrane. So as glaucoma, when you diagnose glaucoma, you want to exclude pseudoexfoliation, you want to exclude pigment dispersion, then you say actually this is a primary open angle glaucoma, right? Same thing here, when you diagnose epiretinal membrane, you want to exclude secondary epiretinal membrane like peripheral, like a retinal tear or previous vein occlusion, or actually uveitis like in this case. And I had a very similar case, very, very similar presentation, and the patient had syphilis. So you have to look carefully. What's in the vitreous? Why is the retina thin or interrupted, or there is problem with the outer retina? And don't just buy that this is an epiretinal membrane that needs peeling. And that's a more typical patient here with Birdshot, and you can see the beautiful lesions here. Right. What does this patient have? Can we type? Okay, so there's a pattern recognition, and that's very important in UVI. So this patient, it's a pattern recognition. This patient has mutes, right? And there's always this pattern recognition, and that's very important in UVIs. And that's again why uveitis, really difficult uveitis case should be handled by uveitis specialists, because there's this pattern recognition where you know it, and sometimes you're wrong. And this patient, actually, some patient with mutes ended up having lymphoma. But as long as you know what you're dealing with and you can understand if it's coming back, if things are getting weird, if getting RPE changes, then you think actually maybe that was just presenting as mute but was not mute. Yes, and FA and ICG, I just showed here to just show the pattern recognition, and of course we get FA and ICG really, and OCT, which is very helpful. So just to few points here that don't do in uveitis. Don't be bold in uveitis. Uveitis is a very humbling specialty. Every now and again, you make a mistake, and when you make a mistake, it actually can result in severe visual loss. So always just be wary what you're doing. Always test the water. Systemic steroid is your friend. Don't use intravitreal steroids in any new case. When the diagnosis is established, yes, fine, use systemic steroid, use intravitreal steroid. Always keep the door open for revising the diagnosis, because there are cases we saw that was like everything said is sarcoidosis with a blood test and response, and then many years later, the patient had CNS lymphoma. So that lesion was actually primary intraocular lymphoma. There's a big pattern recognition. It's like, for example, I heard this somewhere else. You say, like, for example, you see your dad or mom walking and you see them from the back, but you know this is your mom or dad. How did you know? You just, it's a pattern recognition. And that's similar in uveitis. The more you do, the more there is this pattern recognition, but also you need to have like a plan, what to do and how to be safe. That's the end of the presentation. I'll show this vitreous tap sample. And again, my aim from this presentation was not to give you knowledge, but just to give you a flavor of how to think about uveitis cases. And the infection, inflammation, neoplastic or masquerade. And I'm happy to entertain any questions as we're getting this video. I'll shoot two quick things. Can you see my screen or no? Okay, sorry. For some reason I'm getting... so this is a technique I learned. I did not come up with this technique.
Intravitreal stent injection using a vitrectomy trocar.
So this is very useful, especially when you're going to inject lots of things. For example, endophthalmitis. This patient actually had candida infection, and we were taking a tap and injecting voriconazole. So we use a 23 trocar. You can use also 25. And then you tap through the trocar. I give subconjugal lignocaine. And then you inject through the trocar, and then you take it off. I like it. I feel it's like less re-changing of needles and less... like restabbing, and all what you need is to have one trocar. So I like it this way. Then the other technique might be, which is really connected as well, and I really find that very helpful. Again, I was shown this technique. I just modified it a little bit. Is when you're dealing with when you're not really sure what you're dealing with and you want to get a very big sample. So if you do a vitrectomy biopsy dry, you end up getting a very small sample. And the problem is that the eye collapsed. And once as a fellow, the eye collapsed and I went into the lens and we had to remove the lens. So this is a very nice technique that I was taught. I just did this video to just help people set up for the technique. So we put the infusion on air, as you will see here. So the machine goes on air.
Vitrectomy machine priming. Sterile air is passed through the infusion line until all fluid is eliminated to prevent dilution of the vitreous biopsy.
So that pushes the fluid, and then we connect the air to the cutter. And you see fluid coming from the cutter. Because many machines you cannot skip priming.
It can be seen being flushed from the retractor. Then the infusion cannula is reconnected to the infusion line, and a 3 cc syringe is connected to the aspiration arm of the retractor to obtain the vitreous samples. At the start of the procedure, air is temporarily switched off until the infusion tip is confirmed to be in the vitreous cavity. The surgeon performs the cutting with the retractor as the assistant slowly withdraws the plunger. The second and third syringe can be used as needed.
So here, the assistant knows that as the surgeon cuts, they aspirate slowly, and you can have really big sample. You can have up to 2 cc of vitreous without the eye collapsing. I'll show you what happens in the eye in a minute. This is just the view from outside, and then you reconnect and start.
Vitrectomy is carried out just posterior to the oncoming air bubble formed in the vitreous cavity. Here we show the intraoperative view of the surgeon as air enters the vitreous cavity. The overlay in the bottom left corner shows an external view of the same process.
So you're working and dipping down as the air fills the eye, so you have a good view, you can get a big sample and the eye does not collapse. And once you finish, you switch to fluid.
After obtaining the samples, intraocular air is exchanged for balanced saline solution, and vitrectomy is completed. Thanks for watching.
Thank you so much. So fungal endocarditis, they need to be treated at least for 6 weeks. So we tend to treat them for 2 months to 3 months. And we give them oral treatment. We give them oral voriconazole. And if the lesions are raised or they reach into the retina and the vitreous, we give them as well intravitreal injections. But if they are in the choroid, not raised in the choroid, then systemic treatment is enough. Any other questions? For yes, you can go high. We sometimes go higher as well, but usually 4 times a day is equivalent to what we say prednisone 8 times a day. We've went higher with some patients, but you have to be wary of the pressure and the cataract. So a few things really. So sorry, I'm trying to stop share. Yes, okay, all right. So if you're not suspecting filamentous and you're suspecting mainly candida, then fluconazole is very good. It's cheap, it's available, it has less liver toxicity, and is very well tolerated. And we tend to use it. If you are suspecting weird organisms, or fluconazole is not working, then you can use voriconazole. The problem with oral voriconazole is very expensive and it's very liver toxic. So you have really to check the liver. You also may need to check the troughs as well of the drug. So it's a bit of a headache. Infection disease usually helps. Fluconazole is much easier. If the lesions are more into if they are raised lesion, then you want to give intravitreal as well, and you can give amphotericin B or better voriconazole because it's more broad spectrum and less risk of retinal toxicity. But amphotericin B is fine as well. So that's a good question. So a few things. So sometimes it's really difficult to know that it's Fuchs or not, because actually herpetic sometimes can look like it, and sarcoid uveitis or other chronic uveitis look like. So one thing to do is to do a therapeutic test, where you put the patient on 4 times a day prednisone, for example, for 2 weeks, and see what happens to them. If it decreases significantly, it's unlikely it will be Fuchs. Otherwise, usually we don't use steroids. If you find that they are responding to steroids, I think you can keep them on a minimum dose. Importantly, one thing tends to happen is after cataract surgery, things that were characteristic for Fuchs tend to reverse. Like, for example, they can get pigmented KPs, they can get postecyaniki, they can get cystoid macular edema, and also they become responsive to steroids. So just something to note. There was a question about fluocinolone implant. So I think if I did not upset you, Dr. Tariq may kindly invite me for another lecture, then I can talk more about the treatment. But thank you so much, Dr. Tariq. Okay, it seems I did not upset you enough then, which is good, really. So we can talk, but you know, it's like my boss used to say, it's like a cookery. You can go to a restaurant, they serve you something, you eat, you're very happy. You go to another restaurant, they serve you another thing, you eat, you're very happy. At the end, you're full and happy. So you can treat patients systemically, right? Or you can treat them with intravitreal treatment up to Retisert. It depends on how you select, what are the side effects profile. You need to rethink of the adherence to treatment as well. So these are factors you need to factor in. Thank you so much, Dr. Tariq. Thank you. And thank you so much for everyone. All right, thank you. Assalamu alaikum. Goodbye.